What is the most likely diagnosis? Acute myeloid leukemia, chronic lymphocytic leukemia, chronic myeloid leukemia, myelodysplasia, myelofibrosis. A 79-year-old woman was admitted for elective hip replacement surgery. On examination, she was spayed. There was 2 cm splenomegaly, and there were small, discrete axillary lymph nodes. Hemoglobin 107, WBC 34.5, platelets 183. What is the most likely diagnosis?
This old woman has presented with the features of pale 2 cm splenomegaly pointing towards mild splenomegaly and small discrete axillary lymph nodes. Laboratory investigations are showing the evidence of anemia, leukocytosis, and normal platelet counts. We should apply the exclusion theory for this MCQ. But before going through the exclusion theory, let's discuss the fact of splenomegaly. Massive splenomegaly is defined when the largest dimension is greater than 20 cm or greater than 8 inches. And in terms of weight, greater than 1 kg or greater than 2.2 pounds. The largest dimension up to 12 cm is considered normal, and when it is beyond 12 cm, this is known as the splenomegaly. If we analyze the 5 options here, the massive splenomegaly is associated with myelofibrosis and CML, chronic myeloid leukemia. And in our scenario, there was 2 cm splenomegaly. 2 cm splenomegaly means the mild splenomegaly. So let's go for the exclusion theory. Myelofibrosis is a myeloproliferative disorder which is caused by hyperplasia of the abnormal megakaryocytes. Typical presentation would be an elderly patient with the features of fatigue. Fatigue or lethargy is the most common presenting symptom in a patient with myelofibrosis. And the fatigue or lethargy is due to the underlying anemia. Patient with myelofibrosis will also present with the features of massive splenomegaly and hypermetabolic symptoms like weight loss or the night sweats. Laboratory findings would be the evidence of anemia. The early stages of myelofibrosis will have leukocytosis and thrombocytosis, elevated white cell count, and elevated platelet count. And pancytopenia is usually expected during the advanced stages of the myelofibrosis. Lethargy or fatigue is the most common presenting symptom in a patient with myelofibrosis. And if we go for the blood film, myelofibrosis is associated with the teardrop poikilocyte. The blood film is showing the typical teardrop poikilocytes of myelofibrosis. So these are the teardrop poikilocytes. The bone marrow biopsy will show the evidence of dry tap, so the trephine biopsy is often indicated here. Elevated LDH and elevated urate level can also be expected here, which is suggestive of underlying increased cell turnover. Although this is an elderly patient coming up with the features of anemia, the normal platelet counts and the absence of massive splenomegaly is excluding the myelofibrosis. Myelodysplasia or myelodysplastic syndromes, MDS, usually occur due to the genetic mutations in hematopoietic stem cells. Myelodysplasia predominantly affects the older age patient, usually around 70 to 75 years, and patient will come up with the features of pancytopenia. In this scenario, patient is having the leukocytosis and normal platelet count. So the absence of pancytopenia is also excluding the myelodysplasia. The next option is the acute myeloid leukemia, AML. Acute myeloid leukemia may occur in the adults. It may occur as a primary disease or following a secondary transformation of a myeloproliferative disorder. Typical presentation would be features of anemia, neutropenic leukocytosis, thrombocytopenia, and the splenomegaly. Patient may also present with the features of hyperviscosity syndrome or DIC, especially in the APML variant, acute promyelocytic leukemia. APML is the M3 based on the FAB classification of the AML. Acute myeloid leukemia, AML can present acutely with hyperviscosity syndrome. Features of hyperviscosity syndrome may be headache, blurring of vision, renal impairment. Fundoscopic appearance of retinal vasculature will show the evidence of bilateral retinal vein dilatation and tortuosity with retinal hemorrhages. Acute promyelocytic leukemia, APML, is a hematological emergency. Needle-like elongated cytoplasmic inclusions known as ORRODs with myeloblasts are pathognomonic of acute myeloid leukemia or acute promyelocytic leukemia. ORRODs are usually seen via the MPO staining myeloperoxidase. DIC is a severe complication of acute promyelocytic leukemia. APML is associated with 1517 translocation, which causes fusion of the PML and RAR alpha genes, also known as the retinoic acid receptor. Treatment is with all trans-retinoic acid ATRA to force immature granulocyte into maturation to resolve a blast crisis prior to more definitive chemotherapy. Acute myeloid leukemia is unlikely to present as an incidental finding, and the absence of thrombocytopenia is also excluding the acute myeloid leukemia. Chronic myeloid leukemia, CML, this is also known as the CGML, chronic granulocytic myeloid leukemia. So patient will have significant elevation in the granulocyte series. Ben 10 is the animated American science fiction series. We'll use the Ben 10 as a mnemonic to remember the granulocyte series. B for basophil, E for eosinophil, N for neutrophil. So CML will have significant elevation in the granulocyte series, meaning significant elevation of neutrophil, eosinophil, and the basophil. Typical presentation would be features of anemia, significant elevation in granulocyte series, and features of thrombocytosis. Patient will also have elevation in the LDs along with the massive splenomegaly. In this scenario, patient is presenting with mild splenomegaly rather than massive splenomegaly, and small discrete axillary lymph nodes are also the rare findings in case of CML. So the absence of massive splenomegaly and the absence of thrombocytosis is also excluding the CML, chronic myeloid leukemia. So finally, the presence of mild splenomegaly, axillary lymph node involvement with features of anemia, leukocytosis, and normal platelet count in an elderly patient, the most likely diagnosis is the chronic lymphocytic leukemia, CLL. CLL is caused by monoclonal proliferation of the B cell lymphocyte, and CLL may be picked up by an incidental finding of lymphocytosis. And if we go for the peripheral blood film, we will get the features of SMUS cell, also known as the smear cell. This is the peripheral blood film showing the SMUS B cells. These are the SMUS cell or the smear cell. Lymph node involvement is also the cardinal feature of chronic lymphocytic leukemia. For definitive diagnosis of CLL, we can go for the immunophenotyping. Immunophenotyping by flow cytometry is a method used to detect the presence or absence of white blood cell antigens. These antigens are protein structures associated with white blood cells. CLL is usually treated with the FCR regimen, fludarabine, cyclophosphamide, rituximab. And this fludarabine is often associated with the development of transfusion-associated graft versus host disease. And for the prevention of transfusion-associated graft versus host disease, the basic principle would be to go for the irradiated blood cell transfusion. The aim or target of this irradiated blood cell transfusion would be depletion of the donor's white blood cell. And ultimately, the recipient would be protected from the transfusion-associated graft versus host disease. So the mainstay of prevention in case of fludarabine-induced transfusion-associated graft versus host disease in a patient with CLL would be the irradiated blood cell transfusion. So finally, the most likely diagnosis is the chronic lymphocytic leukemia. The presence of splenomegaly, anemia, and lymph node would make chronic lymphocytic leukemia the most likely possibility. Acute myeloid leukemia is unlikely to be diagnosed as an incidental finding and would more likely to be associated with thrombocytopenia. Chronic myeloid leukemia is a possibility, although this is a less common diagnosis and an elevated platelet count would be expected. Myelodysplasia wouldn't usually be associated with a high white count. Myelofibrosis is a possible diagnosis, although the high white count with normal platelet count makes this less likely. It would be expected to request a white cell differential in the clinical setting. And the white cell differential in a clinical setting will show the evidence of significant elevation in lymphocytes in case of CLL. CLL will also have the mild splenomegaly with predominant lymph node involvement.